Hi, it's Dr. Silva. Thank you for joining me today. I'm going to be talking to you about obsessive-compulsive personality disorder. Not obsessive-compulsive disorder, but the personality disorder. And there is an association, there's a relationship. People with anxiety disorders in general tend to be at increased risk for obsessive-compulsive personality, but they're not the same thing. And in fact, most people that have OCD, the majority of people that have OCD do not appear to meet criteria for the personality disorder. So I'll talk a little bit about the other differences between those two. But I do want to say that I myself suffer from obsessive-compulsive disorder. And I've talked about that in other videos. I have a whole playlist about esoteric OCD symptoms. Please check it out. And as much as I have OCD, for the longest time, I would recognize traits in myself and I would tell people that I had obsessive-compulsive personality. And I would say that because I knew that I had OCD stuff, but I didn't think I had OCD. I didn't think I had the actual disorder until I was diagnosed by a colleague. And I'd already been practicing psychiatry for over a decade at that point. When I look closely at the diagnostic criteria for the personality disorder, it's clear that I have a lot of those tendencies, but I don't actually have the personality disorder. And I'm not sure which is worse, OCD or OCD personality. The personality sounds worse, to be honest. But you guys can be the judge of that. This is, of course, according to the DSM-5-TR, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, that is published by the American Psychiatric Association. And OCD personality disorder is a cluster C personality disorder. It is in the quote-unquote worried cluster, along with avoidant and dependent personality disorders, which I'll cover in separate videos. The definition of OCD personality is, quote, a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency, beginning by early adulthood and present in a variety of contexts. And that efficiency one is really speaks to me. And I talk about that in other videos, especially in the esoteric OCD symptoms playlist, about how we do things the hard way. In fact, the video that I just released right before this one was on esoteric OCD symptoms that had to do with choosing the lesser of two evils, doing something that's irrational and time-consuming and wasteful, and it makes no sense, and it's really not the way to do things, but you are suffering that way of doing things because it appears to be the lesser of two evils, where the first evil is really just in your mind, it's just imaginary. And so similarly, patients with OCD personality disorder will often sacrifice efficiency for this ideal of perfectionism. And I'll get into more detail about that later, but that efficiency really jumps out at me. And this diagnosis is indicated by the presence of 4 or more of the following 8 criteria. And I always say in all my other videos, I feel like I'm a broken record here because I say this in every video, but you wouldn't not diagnose this in somebody that only had 3 criteria in real life. If, as a clinician, in your best judgment, this person is an OCD personality, because globally, when you take a step back and you look at their relationships and their decisions and the way they function and what the dysfunction is, then you wouldn't be a stickler about 4 out of 8. That's for research purposes where you get that specific about it. You do have to have dysfunction, though. And one of the criterion that is missing is the one that explicitly states that there must be significant either subjective distress or actual impairment in social, academic, or occupational functioning. And you see that with almost all of the other disorders in the DSM, where it says not only do you have these symptoms, but they cause dysfunction. Either the individual or their family is subjectively distressed by these findings, or they're not functioning well at work, in school, or in their relationships, in their interpersonal relationships, their peer relationships, or their collegial relationships. You don't see that criterion in the personality disorders. However, you're still expected to meet that dysfunction, whether they're 3 out of 8 or 4 out of 8 or 8 out of 8. All right. So Number 1 is preoccupied with details, rules, lists, order, organization, or schedules to the extent that the major point of the activity is lost. These individuals are so preoccupied with attempting to maintain a sense of control that they sometimes miss the whole point. And control is another trigger word for me. When I see control, I've talked before about how worrying itself, and remember that these are anxiety spectrum disorders, that worrying itself is about trying to maintain control over the situation because it gives the illusion of control. When people are worrying, they feel like they're doing something about their problems, whether the problems are real or imagined, and in reality, it's just an illusion. Worrying isn't really doing anything, it's just a symptom. But again, it gets back to the idea of trying to control things. And so when a person with obsessive-compulsive personality disorder is trying to get things done, they're so preoccupied with painstaking attention to rules, trivial details, procedures, lists, schedules, or form that they're inefficient. Again, harkening back to that efficiency idea. These individuals are excessively careful and prone to repetition. We know that about people with OCD, that they tend to repeat. Repeating themselves is something that they often do. In my video on esoteric OCD symptoms, I do talk about how some individuals can't stop talking, and part of that is repeating themselves. My brother-in-law calls it looping. But because these individuals are so focused on detail and the tendency to be repeatedly checking for possible mistakes, they lose track of time. And the DSM gives a very good example. A person with OCD personality who misplaces a list of things to be done, and rather than spending a few moments trying to best recreate that list from their memory, they'll instead spend an inordinate amount of time looking for the list. I can really identify with this. I have done that so many times, but I have insight and I catch myself doing it where I really want to find the list. I know it's here. I know I made it. I went to all the trouble. Maybe there's just 2 or 3 things on that list. It's not that I don't already know what I need to do, but darn it, the list is here somewhere and I'm going to find it. And so you become so focused on the thing that you're trying to do, the procedure of following the list. And then the procedure becomes finding the list because you need the list to follow it. When in fact, if you take a step back, no, you don't need the written down list to follow it because maybe you've already committed it to memory. It can really be irrational. But you enter into dysfunctional territory when you become very rigid and you refuse to deviate from what feels just intuitively what is the right thing to do. And so it is this chemical aberration in your brain that's leading you to want to find that list because that feels like the right thing to do. And it feels, quote unquote, like the wrong thing to do to just recreate it from your memory. And it's because of this chemical problem that you have, whether you call it OCD or whether you call it OCD personality. It occurs in both syndromes. These individuals will also dismiss the fact that other people tend to become annoyed with these delays and these inconveniences that result from this behavior because the individuals are preferentially responding to either their anxiety about making a mistake or their insistence on how things should be done. And this preferential response that I've just alluded to, I talk about in my most recent video on OCD, which is doing things the wrong way, selecting what appears to be the lesser of 2 evils. But it's really because you just have this anxiety about how it's supposed to be done. It's really not a problem at all. It's only a problem in the mind of the individual with these tendencies. But time is so poorly allocated and the most important tasks are often left to the last minute that it really causes problems with efficiency. Number 2, shows perfectionism that interferes with task completion. For example, is unable to complete a project because of his or her own overly strict standards not being met. I talk about all of this stuff in my last video, including a preoccupation with perfectionism. This perfectionism And of course, you can never achieve perfection, right, by definition. But these self-imposed high standards of performance, they cause significant dysfunction and distress in these individuals. This is one arena where the individual who's actually suffering from this disorder has the dysphoria about it because they're trying to do the impossible. They're trying to perfect something and they just can't ever get there, but they become so involved in making attempts that every detail is absolutely perfect that the project is never finished. And one way that I've experienced this is, well, I like to write, I'm a good writer, but I found that every time I went back to reread the chapter that I had thought I had quote unquote finished, I could not help myself in further editing, changing a word here and there, rearranging a phrase, even punctuation, even getting all bogged down in, should I use a semicolon here or what should I do here with punctuation, that I realized after a while that I could not go back and reread a section without editing it. That 100% of the time, no matter how many times I had already rewritten something that I had finished, I found a better way. I found another better way that seemed a better way. And maybe it might seem like a better way because there's all kinds of reasons why it might seem like a good idea to change it. But I realized that I would never be able to not edit it, other than forcing my hand and saying, okay, I'm not going to edit, I'm not going to look at it anymore, that's in the can, that's the way it's going to be. My point is that you will never achieve perfection, and so it can really delay you from not only finishing projects, but even getting started. And this is something that I've talked about with my patients. I have several patients who have told me about this phenomenon, so I know that it's a common one. This all or nothing feeling that they have about completing projects, such that they can't just do a little bit. They have something to do, it's a task, they start putting it off because procrastination is something that is also seen in people with anxiety. And because they can't finish it all in one sitting, like doing your taxes, say for example, then you put it off. I can't finish it now, so I'll do it tomorrow. When I'll sit down, I'll just take care of it and I'll do it all. And a lot of times that's ultimately how they end up getting things done. They just sit down and they tackle it, when it might make more sense to just do a little bit at a time, but it doesn't feel right to them. That just doesn't feel right. The idea that I'm just going to do a little bit, no, it's all or nothing. And that's part of the OCD way of thinking and feeling. A lot of times when a person starts to do something, they get on a roll and they realize, oh, it's not so bad, I'll go ahead and finish it. And it doesn't take as long as they thought it would take. And they do end up finishing it, and they thought, oh, all this time that I've been putting it off, I could have just gotten it done. Because for all the time that they were putting it off, instead, especially individuals that have anxiety disorders, instead they will fret constantly about their to-do list. And I've experienced this. It really is terrible. You feel paralyzed. You feel immobilized. But you say to yourself, and there it is, and you see it. Maybe it's on your desk, in your inbox, literally in your inbox, and you think, I gotta get that done, oh, I'm not getting it done, I gotta get it done. The deadline is approaching. And if there's not a deadline, it's even worse, because that can go on indefinitely. It can go on for months until you finally say to yourself, I'm not gonna do it, let me just accept that I'm not ever gonna do it. Or when you really do have to do it, deadline or no, it eventually gets done. But in the meantime, for all of those many, could be weeks, could be months, the person with OCD personality will fret about it. And the amount of suffering, the amount of anxiety that a person endures by doing that is so much more than the stress that they would experience at actually getting started on doing it, if it's an unpleasant task like your taxes, or the stress that they would feel about not doing it perfectly once they get started, or they don't have enough time, or whatever it is that's causing them to procrastinate it so badly. It is so much less than the accumulated suffering of telling yourself, oh, I gotta get that done, why am I not getting that done, I need to get it done. But that just in the moment feels like that's better than starting it and not finishing it, or starting it and not doing it just perfectly. By the way, I am going to say OCD/OCD personality probably throughout this presentation, because so many of these tendencies, these traits in OCD personality are experienced by people who have OCD. The overlap is huge, hence the name, even though according to the DSM, people with OCD Most of them do not actually have OCD personality, don't meet the criteria for the pervasive dysfunction, especially interpersonally, that you see with OCD personality. So, ladies and gentlemen, I have to interject here. After reviewing this disorder and making this video, I have to say that the difference between OCD and OCD personality is how much it bothers other people. This isn't specifically stated, but I'm going through this and I'm thinking all of these criteria are a part of having obsessive compulsive disorder for most people. Not everybody's going to have every symptom, of course, but almost all of these, except for the miserly spending, apply to me to a certain degree. And I'm thinking to myself, well, what is the difference between obsessive compulsive personality disorder and OCD? And as I go through these criteria, I'm looking at the criteria right now, and the only one that really bothers the individual is criterion number 2, perfectionism that interferes with task completion. That often causes subjective dysphoria for the individual because they're not finishing their tasks, they're not getting stuff done, and that may be causing problems for them occupationally or just in their own personal life. They're not meeting their goals. The hoarding criterion, which is number 5, unable to discard worn out or worthless objects, that one can also sometimes cause subjective distress, but sometimes it doesn't. And sometimes it's not the hoarder that's complaining, but the person that either lives with a hoarder or a family member. But if you look at all of the rest of these, that can't work with others, rigid, stubborn, miserly in their spending, again, a person's not going to complain about that. Other people will notice that they're miserly. And being overconscientious, being inflexible, being overly scrupulous. Some of these I haven't talked about yet because I'm interjecting this, but just to let you know that even the excessively devoted to work to the exclusion of leisure activities, that's the impulse, the compulsion that the person with OCD personality, and OCD is the point I'm making, has. And so they don't mind working through their vacation because that's the impulse they have. They'd rather do that than feel anxious about it. And so when you look at all of these, the difference between OCD and OCD personality is that these cause impairment in interpersonal functioning, in social functioning. And while we don't have an explicit criterion saying it's causing problems in academic, occupational, or social or other areas of functioning, it's clear that this is what bothers other people. And when you look at the personality disorders across the board, it's other people saying there's something wrong with that person. They don't act right. They are paranoid, or they're histrionic, or they're antisocial. It's how they affect other people, really, is how even borderline, as many problems as the borderline has, and the problems that are inherent to the individual with borderline personality, the interpersonal conflict, that's really the core of it. It's their chaotic interpersonal relationships and how they act out in those relationships, and even in professional settings, and especially in hospital settings, how the doctor-patient relationship is adversely affected by that personality style. And so I've had an epiphany here that the difference, apart from a matter of degree, where you could say if you have some or all of these that are really hardcore to the point where you're having actual obsessions and actual compulsions, the difference is interpersonal, because these are compulsions. All of these behaviors, or all of the reluctance when they're avoidant behaviors, like not wanting to go on vacation or not wanting to spend money or what have you, they're all compulsions. They all come from an underlying irrational anxiety that's excessive, that comes from a problem with serotonergic neurotransmission. So anyway, I want to make this point. This is a very important point. That's the difference. That's the difference. And I invite you guys to, especially those of you with OCD, to check out my esoteric OCD symptoms playlist, because that one really gives you an insider view and explores the various facets and the various aspects of OCD that's just not talked about. That's the difference here. All of these bother other people, even the ones that bother the individual. It's other people saying they're rigid, they're stubborn, they don't finish their tasks, they don't work well with others, they micromanage. It's really the way it affects other people. And so there should be a separate criterion, in my opinion, because this really is, it should be all of these things, which means the individual has OCD, mild, moderate, or severe, and whether they have actual obsessions and compulsions, plus or minus, these are compulsions, but there should be a separate criterion, in my opinion, that says, and it drives other people up the wall. Other people don't like it. It causes problems at work, problems at school, and in their relationships. That's what makes this a separate entity from OCD. Because otherwise it's not. It's the same pathophysiology, folks. It may not be the same pathophysiology or specific etiology that is source and disease process in every individual across the board, but in any given individual with these characteristics, it's the same pathophysiology. They're not two separate things. You also see a pattern of exerting extraordinary effort, including working through the night or skipping meals in order to make those deadlines at the last moment. So they're very inefficient with time management. And by the way, stimulants make this worse. For those of you out there with OCD or OCD tendencies, if you take something that increases dopamine, that's going to oppose serotonin, and it's going to make OCD worse, whether you've got a diagnosis or not. And if you don't have it, and you don't have those traits normally, and you don't have tics normally at baseline, stimulants can give you tics. They can give you, and there's an association there between tics and OCD, by the way. Sorry, I just finished a video on OCD and tics. But know this, at one time, I was representing myself pro se in court one time, which I don't recommend doing. And I was writing my pleadings, and I was so wrapped up with having them sound right instead of just getting to the point, making my arguments and moving on, that I would spend an inordinate amount of time. And it was very inefficient, and I would really stress out because there were deadlines. You would have to file pleadings by certain deadlines, and I wasn't going to make it. I would stay up all night. And I was taking Adderall at the time because I thought this will help me power through the night. It will help me with my thinking and I'll get more stuff done. It actually was making it worse. It was exacerbating my perfectionism, and it was making me stay up all night. And it was also heightening the anxiety, the almost the panic that I would feel when I would start to run out of time, and I would see that. And then also as the medication would wear off and I would get rebound ADD, and it would become increasingly hard to organize my thoughts and to really focus. Oh, that was terrible. But I digress. Number 3 is excessively devoted to work and productivity to the exclusion of leisure activities and friendships. This is not accounted for by obvious economic necessity. In other words, you're not holding down 2 jobs because you have to, okay? But these individuals they can't relax. They're workaholics, but they feel compelled to work. So it's not like workaholics who just love their job and could just do it all day. There's anxiety that's driving this behavior. They cannot relax. And when they do take time off or they go on vacation, they do so reluctantly. And they're uncomfortable unless they take something along to work on so that they don't, quote unquote, waste time. If they spend time with friends, it's likely to be involved in some kind of formally organized activity like sports. Hobbies and recreational activities are approached as serious tasks with methodical intensity, requiring careful organization and hard work to master. And again, the emphasis is on perfect performance, perfectionism. These individuals are also prone to turn play into a structured work-like task for their children. And the examples given in the DSM are correcting an infant at play. Anything you do to tell an infant that they're not playing in the proper manner, they're not stacking their blocks in the right way, is a symptom. Or another example the DSM gives is telling a toddler to ride their tricycle in a straight line. Also the control, you see the control aspect there as well. So everything is serious, it's all work and no play, literally. And on that last example, you also see the control. A lot of these behaviors, a lot of these things you might see might involve more than one of these criteria. So in that last example, you see both control, the need to control others, and not relaxing and not playing just for the sake of being playful and spontaneous and having fun. Number 4 is over-conscientious, scrupulous, and inflexible about matters of morality, ethics, or values. And The disclaimer that this is not accounted for by cultural or religious identification. So it's not culturally sanctioned, and it's not because of religious dogma. Although one could argue that religious dogma might lead to the symptom of being inflexible or unreasonably moral, especially in judging other people. But that would not be a facet of obsessive-compulsive personality. That would be a separate problem. But these individuals can be mercilessly self-critical about their own mistakes and very harshly judgmental of others. Individuals with this disorder are rigidly deferential to authority and rules, and they insist on quite literal compliance with no rule bending to extenuating circumstances. And the example given in the DSM is that an individual won't lend $1 to a friend who's short of bus fare because, quote, neither a borrower nor a lender be, or because it would be, quote unquote, bad for the friend's character. And so they're so scrupulous, they're so rigid to not lend a friend $1 so they can get home. What's really the worst thing in that situation? If you take a step back and you look at it logically and you look at it reasonably and you don't have this crazy mental disorder, it would be to lend the $1. Right? So that's a really good example in the DSM. Number 5 is unable to discard worn out or worthless objects even when they have no sentimental value. These individuals will sometimes admit that they are, quote unquote, pack rats. And a favored refrain is, you never know when you might need something. I did a separate video on the hoarding instinct. And I'm not a hoarder, thank God, but I have felt that reluctance to throw certain items away, certain items that in my mind have value or might have value. And that's where the symptom of this comes in that it's not necessarily something that has value for you or that will ever have value for you, but it might have value. If it's really bad, you make a separate diagnosis of hoarding disorder. But what type of items do you typically see? Old parts, broken appliances that they're going to fix. The intention is that they'll fix it, but they never get around to fixing it. That procrastination is indefinite. And also piles of reading material that they're going to get to or that they've partially read, but they're not done reading it. And so there it is in a huge pile. They're going to read it. If they subscribe to a magazine and they get the magazine every week and they just haven't gotten around to that issue, but they're 20 issues behind. And so now there's a stack. And it's trash. It's trash. It should be thrown out and recycled. It's not ever going to be read. This clutter can also result from an accumulation of unfinished projects. And the projects have been sidelined because of a meticulous yet slow work style. Again, perfectionism coming into play. Again, there's a lot of overlap here between these criteria. And when other people get rid of the things they've saved, these individuals, obviously, they get upset about it. Number 6 is reluctant to delegate tasks or to work with others unless they submit to exactly his or her way of doing things, i.e., they micromanage. That is when they do actually delegate things. A lot of times they resist that. They feel like they have to do everything themselves. If you want it done the right way, do it yourselves. They believe that to the extreme, to the extent that they will reject offers of help because they truly believe that nobody else can do it right. And even if it causes them resentment, they might resent the fact that nobody's helping them or that they have to do it themselves, even if they've rejected offers of help. So it can be quite irrational. Number 7, adopts a miserly spending style toward both self and others. Money is viewed as something to be hoarded for future catastrophes. This is definitely not me. I have to say I have OCD and I can identify with most of these traits. They're severe enough to me to the extent that they're symptoms, but this one definitely doesn't apply to me. I am the opposite. I'm profligate with my spending, but I think that has to do with the hoarding instinct, which is the acquisition of things, being a collector. I don't have this particular symptom because I have another one that's also part of OCD that is diametrically opposed. So I don't know if I would have this worry. Anxiety, again, underlies it, right? It's the fear you want to squirrel away your money because you might need it for a rainy day. And so it comes across as not wanting to spend money. But there are always exceptions, and again, you only need 4 out of 8 to officially make this diagnosis in the context of a research study, and enough that are severe enough that they cause dysfunction to make the diagnosis in the real world. Number 8 shows rigidity and stubbornness. I'm stubborn. I don't know if it's part of my OCD. When it's a part of OCD, it's because there is one quote-unquote correct way of doing things, and these individuals really have trouble. They have a reluctant anxiety to go along with anyone else's ideas because, no, that's not the right way. This is the right way. And however they came to that conclusion, however they learned to do that. Being stubborn, when it's part of OCD personality, it's not just because you're stubborn or because you're full of yourself and you always think that you know best and that you're right and other people are wrong. It's because there's just one right way, and however you have come to that conclusion or however you figured it out, whatever authority you're going on, you're inflexible. Now you can't open your mind to the prospect that maybe you should reconsider, or maybe there's not one right way to do things in every context or at all. But you're also supposed to not include those behaviors that reflect habit, customs, or interpersonal styles that are culturally sanctioned by the individual's reference group. So, like before with the mores, if this is what's dictated to you by your culture, everybody or most people in your culture do it this way or think this way or behave in this way, well, obviously all of those millions of people don't have OCD personality, and so that's normal for their culture. It's quote-unquote culturally sanctioned. This disorder occurs equally in men and women. It seems to be equally prevalent, and it is distinguished from obsessive-compulsive disorder, even though all of these symptoms overlap with OCD and can be found in OCD. It's differentiated by the DSM, which states that people with OCD have quote-unquote true obsessions and compulsions. Also, according to the DSM, in terms of epidemiology, it does appear that the majority of individuals with OCD do not have, quote, a pattern of behavior that meets criteria for this personality disorder, close quotes. It's interesting that they focus on behavior because really OCD, it obviously does translate into problematic behaviors, but OCD is something that occurs in the mind of the person with OCD. It dictates their thoughts, and it does spill over into behaviors, but it's also things that a person with OCD is not doing. It's also avoidant behaviors. It might not be evident to another person, or that might not impact another person, and so it would not impact their social functioning. But it's still part of OCD. It's still anxiety driven. It's still irrational or excessive. It only occurs in the mind of the person with OCD. There's a lot of also crossover, a lot of comorbidity with other anxiety disorders, including generalized anxiety and panic disorder and social phobia and other phobias, agoraphobia, separation anxiety disorder, PTSD, you name it, because the aberration is the same. And individuals that have two major anxiety syndromes, the problem is presumably with their serotonergic neurotransmission, and the pathophysiology is presumably the same. The etiology is presumably the same. It's manifesting as one thing in this individual. It's like a Venn diagram, whereas in another person with the same etiology and even the same pathophysiology, you might have a different expression due to other variables that may or may not be genetic. And so finally, the DSM notes that obsessive-compulsive personality traits in moderation might be especially adaptive, particularly in situations that reward high performance. Only when the traits are inflexible, maladaptive, and persisting and cause significant functional impairment or subjective distress do they constitute obsessive-compulsive personality disorder. And so even though it's not a separate criterion, the way you see in other disorders in the DSM, it's still noted in the discussion of this syndrome that it must cause clinically significant, meaning it requires treatment, or people present for treatment, or families present the patient for treatment to allay significant subjective distress or social, academic, or occupational functioning, or dysfunction in other important areas of life.